Right. Thank you so much for that. Um, we do have some questions coming in, so we'll just jump right into it if that's okay with you.
Yeah, that sounds good.
Okay. So unfortunately, we have a word limitation, so this is cut off a little bit. But do you find a utility in clinical practice to use labels such as neuropathic pain or complex regional pain syndrome to identify a little bit more what happens with your client and for the orientation of treatment?
So are the labels, do we have utility clinically? I think from the standpoint of explanations, it makes sense. Having the word neuropathic makes us think a particular way about someone's experience, and then more importantly, a potential variable to influence. I don't know how much that alters all situations, meaning, I don't know that I would use the word neuropathic to a patient to explain their situation. A lot of times, like if we're taking the example of someone having radiculopathy symptoms with low back pain, it's really, for the most part, based on what we look at current evidence, not going to alter a whole lot, typically speaking, for recommendations and management. So I don't know that I would explain it as you're having neuropathic pain, and that's why you're having radiculopathy symptoms. I understand why we have that label. I probably have less issue with neuropathic than I would something like neuroplastic. I think is the term the ISPs like presented forth for central related issues. For CRPS, again, I understand clinically why we have those labels. I just don't know how beneficial it is to everyone in all situations. I certainly think some patients, and this is the hard part of these conversations, is we want generalities. I think some patients would respond positively to neuropathic as well as CRPS. I think other patients wouldn't respond positively to it. So it's this weird being able to have a conversation and mold your communication to the individual in front of you is very important. But it's complex. I don't know that it would probably depend on the day of the week that you talk to me and my mindset of where I would lean on that topic. Hopefully that provided some insight.
Yeah, no, it was a great response. Another question. So you were mentioning at the end just the how pain is something that's codified at like a societal level, and then it's like malleable, like on an individual level. In your practice, as you see people perhaps with some of that misinformation you were talking about that is kind of contributed to their understanding or even their experience of pain, how do you handle that misinformation,
Yeah.
especially if that information has come from people that they find reliable or that they respect?
Yeah, this is a great question. I get asked quite regularly. It's difficult and complex, and I am fully willing to admit that I screw it up all the time. There have certainly been times where I thought I had stronger therapeutic alliance than I actually did, and I challenged beliefs a little bit too quickly, too soon, and that didn't work out well. And that happens. It's probably one of the few times in which I say, experience matters in this regard. Getting reps under your belt, having difficult conversations with people, oddly makes you better at having difficult conversations with people. So it ultimately comes down to, if I think I'm only going to see someone a single time, like a single one-off consultation, odds are I'm going to go a little more aggressively with confronting misinformation because I don't think I'm going to have another opportunity. If it's someone I know I'm going to work with a lot, then I start, at least in my own mind, trying to think about kind of a tiered approach. So what's like most important right now that we discuss versus maybe some other beliefs that aren't so great for their context, but not as necessary for me to go after right this minute. And it's just a process, and it ultimately comes down to trust, right? If someone came up to me that I didn't like very much, that I would label it as like an enemy or something, they could say anything in the world, and it doesn't mean I'm going to listen to them. And so it really takes like creating a kind of therapeutic relationship and alliance and bond with the individual to start kind of breaking down some barriers and addressing misinformation.
Awesome. Okay, and another question. So you have throughout your talk quoted a lot of different sources for pain. So I'd like to just ask, how did you start going down that road of, because many people will be like, yeah, the IS definition of pain. How did you get started on that road of of going outside of just the one posted definition and into all of those other thoughts and definitions from other researchers and philosophers and such.
Yeah, I think a lot of it was just the people around me. I had, very supportive mentors who encouraged critical thinking. I was, classically trained as a chiropractor, which would have been very easy for me to fall into very reductionist thinking and, thinking everything that came through my door was this kind of mythical thing of a subluxation and went on with life. But for whatever reason, I was in a good position that I was surrounded by positive mentors who encouraged me to think more critically. And then linguistics and kind of analytical linguistics, I don't know, I just fell into it. Like when I started looking into this and looking at definitions and then how that influences, our world and influences us, it led to reading others' definitions and then philosophical works like Wittgenstein and others. And so I think at this point, for me, it's a bit of an obsession. So I see something like I'm finishing reading The Birth of the Clinic by Foucault now. And so it's just like, what's the next text that I had no education from it in my prior studies that's going to influence how I could try to help someone in clinical practice today?
I think just some of my thoughts on what you just said is I think that that's such an amazing thing, and actually something that's really amazing that's happened at the San Diego Pain Summit over the last several years is kind of getting outside of that, well, this is how I was trained, and really not even necessarily challenging or dismissing what we've done in the past, but really like, what else is out there? And it's hard to know where to go. So it's those mentors and those people you interact with who can really start to change direction or change your direction, my direction. I'm not speaking
Absolutely.
for you.
Yeah, no, that's very true.
Awesome. So we're getting close to the end. Do you have anything that you, because it sounds like you recorded this a bit earlier than the beginning of October. Is there anything now after you rewatched it that you wish you would have added?
That's a good question. I think any of those beginning points where I presented 3 objectives, they could be entire courses in their own right, and which is really hard, like especially if you're beginning to dip your toe in this like different way of thinking. These fields are vast, especially philosophy, cognitive science, and just pick something and start heading down that direction and see where it leads you. I really hope anytime I publicly teach, I want folks to go read citations because I just don't want them to take my word. Like you need to go through this process and figure things out for yourself and see how it influences you. I don't know there would be anything specific. I know the only thing that comes to mind is Peter actually just released another great paper I think folks should go read, specifically on metaphors, Stillwell. And I'm totally blanking on the name, but I just posted about it on my Instagram feed. But he talks very openly about metaphors, and his wife did some art actually that she drew representations of things that they witnessed in clinical patient discussions. And I think it's a great article. I would have probably included it if I would have read it. It just came out this month. So
awesome. That is always fun to get a lead on a new article that maybe hasn't come across someone else's feed just yet.
Yeah.
Okay. So we don't have any other questions right now. So now what we will do is we are going to move over to the discussion session. So the discussion is for everyone who has those backstage passes. So you can head on over to Zoom. Everybody else, I thought I wrote down my instructions. 3:30 is what's up next for you. So 3:30 Pacific Standard Time will be Mark Milligan in the breakout rooms. So if you have anything else, you can email questions to question@SanDiegoPainSummit.com. And then backstage pass holders, we'll see you in a moment. Everyone else, we'll see you at 3:30.